Very good evening to you all. Let's start another chapter of our therapeutic forum of Sri Lanka College of Internal Medicine. This platform was initiated to uplift the care and the knowledge of the physician community. And without a further ado, let me cordially invite Dr. Suranga Malikama, President Sri Lanka College of Internal Medicine, to address the gathering. Over to you, Dr. Suranga Malikama.
Good evening, everyone. Welcome to today's therapeutic forum conducted by SSM, Sri Lanka College of Medicine. I extend my gratitude to all of you for joining us today. And a special note of welcome to our speaker today, Dr. Anushka Mudalige, consultant intensivist, whom I got to know when I was at Ragama, Colombo North Teaching Hospital. Thank you for joining with us today. And I extend my heartfelt gratitude to Ranga, the coordinator of Therapeutic Forum. And also I appreciate the technical support given by Gets Pharma for our series of Therapeutic Forum. And finally, once again, I thank everyone for joining today with us for the Therapeutic Forum. And without further ado, I invite Ranga to introduce our speaker properly. Thank you very much.
Thank you, Dr. Surangamarigama. Dr. Anushka Mudalige, it's my privilege to introduce our speaker, board certified intensivist at intensive care unit of Colombo North Teaching Hospital, Ragama, Sri Lanka, MBBS Faculty of Medicine, University of Colombo, MD Anesthesiology in 2015 from the Postgraduate Institute of Medicine, University of Colombo, Fellowship in Royal College of Anesthesiologists, Fellowship in Faculty of Intensive Care Medicine of the Royal College of Anesthesiologists, European Diploma in Intensive Care, and she is Secretary, Scientific Affairs and Congress Chair of the Ceylon College of Critical Care Specialists, and she's a member of the European Society of Intensive Care Medicine, Indian Society of Critical Care Medicine, Association of Anesthetists of Great Britain and Ireland, and Sri Lanka Medical Association. And she's also a member of the editorial board of Critical Care Communication in 2021 and current. And she's an instructor in European Resuscitation Council Advanced Life Support course. She has special interest in ultrasonography, echocardiogram in critically ill patients. Over to you, Dr. Anushka Mdulige.
Thank you very much, Ranga, for that very kind introduction. And also, Suranga, I would like to thank you for giving me this opportunity at the College of Internal Medicine. I consider this as an honor to be talking to this prestige forum right now. So I'll start off, I'll share my slides. So the topic for today would be to talk on vasopressors and ionotropes, which is kind of something essential for us to know, but in a way that if you actually do not know into a kind of a depth, you will get kind of confused in managing your patients using these drugs. And it's not a good topic to talk at this hour at the night, especially when it's a pharmacology-based topic. But I'll try to keep you interested in what I say, and let's see how it goes. So just give me a second. The slides are not moving. Okay, yeah, sorry about that. So the outline of the talk would be to understand the basic pharmacological effects of vasopressors, ionotropes, and inodilators. So I will try to go very not into depth, but I'll try to give you an idea how these drugs work and the physiological basis of selecting the most appropriate drug to support the shocked patient. And also a little bit of practical approach to use vasopressors and inotropes, which will be dealt into patients that we have managed in ICU. So let's first move on to the classification of vasopressors and inotropes. So broadly, they are divided into 5 groups, I would say. And the major group would be the catecholamines, which are here. And let's see the point. Yeah. So of the catecholamines, mainly it would be noradrenaline and adrenaline and dopamine. And also we use dobutamine, which is a synthetic catecholamine. Apart from that, there is isoprenoline also. The major vasopressors that we use, apart from noradrenaline, would be our vasopressin. Apart from that, there are pure vasopressors here also, but the major one would be vasopressin. And there are the newer drugs. They are not new, actually. They've been here, used a lot, but we are not kind of used to these drugs. These are inodilators, the phosphodiesterase inhibitors and the calcium sensitizers, which is milrinone and levosimendan. So these are the basic drugs that I will be talking about during this talk. So first, let's look at the catecholamines. I know this it looks a bit too much of pharmacology, but let's try to understand very minimum basic pharmacology. So catecholamines are these structures which has this phenyl group, phenol group with these 2 hydroxyl groups attached to it. Anything that has that, it's a catecholamine. So it is made from this tyrosine, which is an essential amino acid that we take from fruit. And this undergoes a series of kind of reactions to form dopamine, then norepinephrine, and then epinephrine. So it's a serial reaction cascade that leads to formation of these drugs, these hormones inside our body. So how do they act? Let's just see. So mainly you have to know that they act on 2 places. One is the heart. So in the heart, on what do they act? It's the beta-1 receptor. So on the beta-1 receptor, what they do is all these catecholamines, when they act on the beta-1, they increase something that this enzyme called this adenylatase cyclase, which will ultimately increase calcium inside the myocyte. When there's calcium, there's going to be myosin-actin interaction. And when these drugs also enhance the calcium being taken back into the sarcolemma as a result, relaxation is also better in the when the beta-1 is stimulated. So positive chronotrophy, inotrophy, as well as relaxation, lusotrophy is there. So apart from acting on the heart on the beta-1 receptor, they also act on the vasculature. So the main 2 receptors, they act on the vasculature. One would be the alpha-1 receptor. So this is mainly noradrenaline, but all catecholamines act on this. And here it's a different enzyme. It's a phospholipase C. But ultimately, that also what it does is it increases the calcium inside the smooth muscle cell, thereby causing vasoconstriction. On the other hand, there's another receptor, which is the beta-2 receptor. Again, all catecholamines act on this. And here, again, adenylase cyclase is stimulated. Thereby, now, like in the myocyte, it will not increase the calcium inside the cell, but it will actually put the calcium back into the sarcolemma. Because of the deprivation of calcium, there is going to be vasodilatation. So alpha-1 will cause vasoconstriction, beta-2 will cause vasodilatation in the smooth muscles. And yes, and then after that, we have, let's have a little talk about, so this alpha-1 and alpha-2. So alpha-1 causes mainly vasoconstriction, and alpha-2 also causes a little bit of vasoconstriction. And there is a beta-1 receptors in the heart, which will cause inotropy and chronotrophy, as I mentioned, and beta-2, it will cause smooth muscle relaxation in the vessels. They have a whole lot of other effects, but I'm just going to talk about this. And apart from the alpha and the beta, these catecholamines act on dopamine receptors. This is only by dopamine, which is a natural catecholamine in the body. So there are D1 and D2 like receptors, which are then sub-classified into 5 groups. You don't need to know this, but ultimately what they do, the dopamine stimulates the dopamine receptor. It causes vascular smooth muscle relaxation, and these dopamine are predominantly located on the splanchnic and the renal vasculature. So in a nutshell, if you look at the drugs, let's see why they are different when they act. So epinephrine or adrenaline acts on all 4 receptors, alpha and beta, 1, 2. Whereas norepinephrine also acts on all 4, but its predominant action is on alpha 1. Whereas on adrenaline, it is mainly on the beta. And if you consider dobutamine, which is a synthetic catecholamine, its main action is on the betas. It hardly has a little bit of action on alpha. And dopamine acts on dopamine receptors, alpha 1 and beta 1 receptors. So depending on their affinity or towards the receptor, their actions will differ. Let's see how that happens. So for alpha 1, as I said, norepinephrine has the highest affinity. Epinephrine is less than that. And for beta 1, both adrenaline and noradrenaline, I'm using the same term epinephrine and adrenaline. Norepinephrine and noradrenaline are synonymous. So they have both the same affinity. For beta 2, adrenaline or epinephrine has a very high affinity compared to norepinephrine or noradrenaline. So let's move on to adrenaline. So what happens? Let's just compare adrenaline and noradrenaline. So as I said, adrenaline has more potential to work on beta receptors. As a result, it will increase your heart rate. This is your heart rate. It will go up when you start adrenaline. And what happened to the peripheral resistance? Because it acts on the beta 2, it has more high affinity for beta 2, it will cause vasodilatation. As a result, the peripheral resistance will go down. As a result, your diastolic blood pressure will go down a little bit. But because it has a positive chronotrophy and inotropy, the systolic blood pressure will go up. Now, compared to noradrenaline, what will noradrenaline do? It has main effects on alpha receptors. So it will cause an increase in the peripheral resistance. So it will go up. When peripheral resistance goes up, your diastolic blood pressure will go up. Also, it has some action on the beta cells also, beta receptors. As a result, the systolic blood pressure will go up because the cardiac output goes up. But because the baroreceptors now will feel this rise in the blood pressure, it will cause a bradycardia. So when you start an NORAD, you might see a bradycardia, but it's very rare because there are other confounding factors that will overcome this bradycardia. But what you should see is a reflex bradycardia. So now in healthy humans, if you use adrenaline, what happens is the cardiac output goes up because of the chronotrophy and the ionotropy, and the SVR will go down. The ejection fraction will also go up because there's more blood being pushed out from the left ventricle. As a result, the systolic blood pressure will go up because the cardiac output is increased, but the mean arterial pressure will come a little bit down because the diastolic pressure is coming down because of the vasodilatation. And because of the positive chronotrophy, the heart rate will go up. Now, what will happen in a patient who's in septic shock? These patients already have a low SVR to begin with. So they are already, the beta 2 receptors are like kind of causing their vasodilatation because of the sepsis itself. And now you have started at adrenaline. Now the beta effect will bring the cardiac output up. And when the dose goes up, the adrenaline's alpha stimulation will start working. And as a result, the SVR will all of a sudden start rising at a point. So your mean arterial pressure and your heart rate will go up. Now, in cardiogenic shock, what will happen? The SVR is already high because of the sympathetic activity, because of the low cardiac output. The cardiac output is low, the SVR is very high. And you have started adrenaline, and the beta adrenergic effect will bring the cardiac output up. Now, the beta 2 effect will start acting on. It will start vasodilating, and the SVR will go down. The combined effect would be a slight rise in your mean arterial pressure, and there's also going to be a rise in your heart rate also. So just remember how adrenaline works in septic shock and cardiogenic shock. And when the inotropy and the chronotropy increases, unfortunately, adrenaline increases the oxygen consumption by the myocyte by about 40%, which is kind of disadvantageous because especially in cardiogenic shock, where you want to maintain the supply and the balance of the oxygen demand. So keep that in mind when we are using adrenaline at high doses. Apart from these, adrenaline also, there are alpha receptors in the pulmonary vasculature. So it will cause pulmonary artery vasoconstriction, increase in the pulmonary artery pressure. And also because of the beta effects, the right ventricular contraction will go up. So it's not the ideal for a pulmonary hypertensive patient. Also, it will cause hyperglycemia because there's an insulin resistance and there is gluconeogenesis, lipolysis, protein breakdown, and it will make you ready for a sugar rush. And there's also in these smooth muscles, the skeletal muscles, because of the beta-2 effect, it causes an increase in the sodium-potassium ATPase activity. This will need the skeletal muscle to produce more energy. As a result, there is going to be a hyperlactemia. So irrespective of the vasoconstriction that occurs, there is going to be hyperlactemia if you use adrenaline. And because of the increased activity of the sodium-potassium pump, the potassium will be taken back into the cell. So there will be a resultant hypokalemia. Because of the positive chronotrophy, ionotrophy, and the hypokalemia, these patients are prone to have arrhythmias. So adrenaline comes in this small amber-colored vial, where there will be 1 milligram in 1 milliliter. This strength of adrenaline is 1 in 10,000. So if you take that whole 1 milliliter, that would be 1 milligram of adrenaline. That is a huge dose. And let's just talk about the doses. So in anaphylaxis, you just take half of this vial, 0.5, and give it IM to the anterolateral aspect of the thigh. Make sure the needle is long enough so it reaches the intramuscular compartment. And if you're using bradycardia, you will use much less doses. In anaphylaxis, this is a quite high dose. And here, what you are trying to aim in anaphylaxis is profound vasoconstriction. When you give high doses of adrenaline, it will start acting more on the alpha receptors rather than the beta receptors. So you're causing a vasoconstriction, thereby causing all the blood to come back into the heart. Where in bradycardia, you just want the beta receptors to work. So you just start with low doses, 2 to 10 mics per min as an infusion. So that's a very low dose. In cardiac arrest, that's the highest dose that you would use of adrenaline as a bolus. So you use the whole vial, you dilute it up to 10 ml and you give it as a bolus in one go and you repeat it every other cycle. So this is again to get the alpha activity of adrenaline, not the beta activity, so that all the blood will come back to the heart and the heart will start pumping when the venous return is increased. Apart from these uses, you can use it as for stridor when there is laryngeal edema. Up to 5 milligrams of adrenaline, that is 5 vials of adrenaline, you can put into the nebulizing chamber and can nebulize. It causes vasoconstriction of the larynx. And it is used as subcutaneous with lignocaine for local anesthetic, and it's also used topically as well in the eye. So these are some contraindications. So obviously, any patient who has a high sympathetic drive, like in pheochromocytomas, thyrotoxicosis, or patients who have arrhythmias, hypertension, you would try to avoid it. And any heart condition where their increased contraction is not good for the heart, like Takotsubo or Hokum, you would try to avoid it. And arrhythmias, catecholaminergic polymorphic VTs, you would avoid adrenaline. So with covering adrenaline, let's move on to noradrenaline, which is the daughter of dopamine and the mother of adrenaline. So I think I already spoke to you how it acts. Now, if you start a noradrenaline infusion, what happens? Alpha effect predominates, so the diastolic blood pressure will go up. And there will be beta effect also. As a result, the systolic blood pressure will go up. The MAP will go up significantly. The baroreflex will cause a bradycardia. Now, the usual dose that we use is up to about 0.5 to 0.8. Now, up to that point, as you can see, the blood pressure, the systolic and the diastolic will rise kind of linearly, right? But afterwards, and there will be a bradycardia. The purple line denotes the heart rate. But afterwards, when you go to higher doses, as you can see, the diastolic pressure will now start coming down. This is because at higher doses, the beta-2 activity of noradrenaline will start working. So the pulse pressure will go up. And when there's after about 0.75 of 1 mics per kg of noradrenaline, there's maximal vasoconstriction. So the the blood pressure will not further go up. And when there is a high rise in the afterload, the heart actually cannot expel the blood into the circulation. So it will come to a halt. The blood pressure will not rise from that point onwards. And because of the beta effects, there will be a rise in the heart rate. And because the cardiac output now is slowing down because of the increase in the afterload, the cardiac output actually goes down. So this is deleterious. So you should not go beyond the doses that are recommended of noradrenaline. So I have already talked about the effects of noradrenaline on blood pressure. Now what happens on the central venous pressure? So in a vasodilated patient, such as in sepsis, the venous system is just lax. And when you give fluid for these patients, because in sepsis we were taught to give fluid, the lax system will just, entertain all that fluid. It will not push it back to the heart. But if you start noradrenaline, although the CVP does not go up, if just a bit of noradrenaline is touched on the vein, it will start vasoconstricting. And in these patients, if you give fluid, the patient will be much fluid responsive, and you can actually see a rise in the CVP. So the possibility of starting noradrenaline early in sepsis has come up with this theory. So we do not give up to 3 liters of fluid, then start noradrenaline. We start the fluid, and along with it, we start noradrenaline. Now, on the coronary, pulmonary, and cerebral vessels all have alpha-1 receptors. So as a result, it will cause vasoconstriction. So, but thinking of this, shall we not start noradrenaline on patients who are hypotensive, thinking it will cause ischemia or pulmonary hypertension? So that is where we actually have to weigh the risk and the benefit and take the decision to give the maximum benefit to the patient. So noradrenaline comes in this vial to Sri Lanka, where there is 2 ml of, and it contains 2 milligrams of noradrenaline. It comes as noradrenaline tartrate 4 milligram, but the pure noradrenaline is only 2 milligram in that vial. And the indications here would be septic shock, cardiogenic shock. So cardiogenic shock, I will talk to you later on, whether there is indication for starting noradrenaline. And other undifferentiated shocks and post-cardiac surgery shock. And the recommended dose is 0.1 to 0.5 micrograms per kilogram per minute. Both adrenaline, all these catecholamines are prescribed as per minute doses because their half-lives are very short, about 2 to 3 minutes. They have been degraded by MOAs and COMTs of the liver and the gut very quickly. So as a result, you have to give it as a per minute dose. And when you're changing the syringes also, if you have not prepared the next noradrenaline syringe, even that time is enough for the patient to crash because the action just weans off very quickly. And noradrenaline and all these catecholamines actually need a normal pH to work. It's because there's an uncoupling between the drug and the receptor when there is acidosis. So you might have to you have to actually correct the pH when you're using these drugs. And also the preparation is quite acidic. It's because it's very unstable in physiological pH. So do not use it along with a basic drug such as sodium bicarbonate. So it will actually disintegrate the drug very soon. So try to use it on 2 separate lines when you're using it. So the adverse effects are as for adrenaline, but the ischemic injury here is much higher because of the alpha-1 effect. Otherwise, everything else is kind of the same as for adrenaline. And it should not be used again in obstructive cardiomyopathies where you do not want too much of inotropy. And when the patient is dehydrated, there's no point in squeezing the vessels when you don't have adequate volume. And in mesenteric ischemia, again, there are alpha-1 receptors which will worsen this. Okay, then we will move on to the synthetic catecholamine, which is an inodilator. All this time we were talking about vasoconstrictors and inotropes, but now this is dobutamine is an inodilator. So dobutamine acts on beta-1 and beta-2 because of the beta-1 positive chronotrophy and inotrophy. Because of the beta-2, there's going to be vasodilatation. So when you use it, what happens? Because of the positive chronotrophy, the heart rate goes up much higher than sometimes even adrenaline. And the diastolic pressure doesn't go that much high because of the beta-2 effect. And the systolic blood pressure goes up because the cardiac output is increased. So the MAP goes up a little bit, but not as much as it does for noradrenaline. And if you look at the doses that we use, it's usually 5, 10, 15. So when you start at 5, the cardiac index starts going up. and the systemic vascular resistance starts going down. And at a point, they intersect. And you can see at this point, the blood pressure actually goes up a little bit because of the rise in the cardiac index. But from this point onwards, it actually starts going down, especially the diastolic pressure. And with high doses, the heart rate goes haywire. So be cautious when you're using dobutamine in high doses. So it comes as this 250 milligram vial. And the main indications here would be cardiogenic shock, because it has mainly this inotropy and chronotrophic effect and vasodilatory properties, which is good for the heart. Low cardiac output states following cardiac surgery, decompensated left ventricular heart failure. And is there a place for septic shock? Now, this dobutamine causes vasodilatation. Septic shock, the pathognomic feature is vasodilation. Can we use it? Let's see in the cases later on. So the dose is 5 to 15 mics per kg per minute. So the breakdown is the same for noradrenaline and adrenaline, very short half-life. Caution, again, if you do not want a heart to be, hyperdynamic, you don't use it, like in cardiomyopathies, fragile ventricle aneurysms, etc. Okay, dopamine. So dopamine acts on three main receptors, as I said, beta-1, alpha-1, and dopamine receptors. So its action depends on the dose that we use. At low dose, 0.5 to 2 mics per kg per min, it mainly acts on the D1 and D2. So it causes vasodilatation in the mesenteric as well as the renal circulation. That's why this renoprotective dose of dopamine came up earlier. So they thought in sepsis, it would be better to get a vasodilatation for the kidney. So they recommended it. They used to recommend it earlier. Now in moderate doses, 2 to 10, the beta effects come up. So there is going to be an increase in heart rate and an increase in the cardiac contractions. And at high doses, more than 10, there's going to be alpha, peripheral vasoconstriction. So dopamine is quite a cheap drug compared to noradrenaline. It's very cheap. And so we used to have dopamine all over the country. About 10 years ago, dopamine was the kind of the vasopressor that we used. And it could be actually given through peripheral vessels as opposed to adrenaline, noradrenaline, which causes vasoconstriction and ischemia. So there are much advantages of dopamine. But why has its kind of use has gone down? It's because of this paper that was published in the New England Journal in 2010, where they compared dopamine and norepinephrine in treatment of shock of any type. And here they looked at the probability of survival. If you look at the two groups, survival is actually the same. So in any shock, if you use noradrenaline or dopamine, the number of days the patient lives doesn't change. So then why did they do not recommend dopamine over noradrenaline? They looked at these secondary outcomes, so support for days, support-free days, the length of stay, causes of death, and so many other things. And if you look at the p-value, most of them are not significant except for this one, which is the arrhythmia rate. If you look at atrial and ventricular arrhythmia rates, it's much higher and it's statistically significant. And ultimately, they gave this forest plot where in any type of shock, noradrenaline is better than dopamine in reducing the risk of any adverse effect. And in the subcardiogenic subgroup, they actually showed an increased mortality in patients who use dopamine. So actually, in cardiogenic shock, dopamine is not recommended to be used. But in other types of shocks, yes, you can use it, keeping an eye on the level, the heart rate. So then we'll move on to our isolated vasopressor, which is vasopressin. So this acts only on the vascular smooth muscle, and it acts on this transmembrane V1 receptor on the vascular smooth muscles. And here, as the alpha-1 receptor, it increases this phospholipase C and thereby increases calcium and thereby causes vasoconstriction. This is a very profound vasoconstriction that vasopressin does more than noradrenaline sometimes. And the vasopressin also acts on the V2 receptor in the kidney, which causes water retention, which we are not going to talk about here. So let's look at the relative vasopressin deficiency in shock states. Look at this patient's blood pressure is slowly coming down. And vasopressin is supposed to cause vasoconstriction in this patient. And it's secreted from the posterior pituitary and senses the osmolality and goes up. But it should stay at a higher level because there's persistent low blood pressure, but it goes down at a point. It must be that the posterior pituitary is running out of vasopressin at this point. So this actually justifies the use of vasopressin in any shock state, actually. And in animals, what they have seen compared these dose effect curves compared to noradrenaline, vasopressin has a much higher effectiveness in increasing the blood pressure. But when you compare it in humans, there's not much of a difference between noradrenaline and vasopressin, but there's a huge difference if you add noradrenaline to vasopressin. So the summative effect is actually more than the addition of the individual effects of vasopressin and noradrenaline alone. So that's why when you start noradrenaline and when the dose is going up, do not wait till it goes to very high levels, but you can start a bit of vasopressin, especially in septic shock when there is a vasoplegia. And the other added advantage is it does not depend on the pH for its activity. So acidosis will not cause any problem with vasopressin. But on the other hand, as you can see, the blood pressure does go up, but the cardiac index goes down. This is because there's no activity on the heart and there's increase in afterload. So the heart cannot pump against this afterload. So the cardiac index goes down very significantly beyond the levels of the recommended maximum doses. And if you look at dose against the magnitude of effect, the cardiac output tries to remain within normal, but it goes slightly down. But after 2 units, it goes drastically down. And look at the coronary vascular resistance. So during the doses that you use for treatment, it rises, but not that much. But after 2, it just keeps on rising very fast. So that you have to keep in mind when using vasopressin. So it comes in this vial where there's 20 units. So do you dilute it and use it in the appropriate concentrations? So the indication was again published in the New England Journal of Medicine, vasopressin versus norepinephrine. In septic shock, they have found there's no difference in outcome. So vasopressin is as equally effective as noradrenaline. So you add it as the second vasopressor after noradrenaline. And what about cardiogenic shock? Do we use that? Let's talk about that later on in the presentation. And especially in cases where HOCM, where you do not want much of inotropy, you can use this. There are other uses of vasopressin here that I have mentioned, but this is not for cardiovascular supports. So the dose is 0.1 to 2 units per hour as an infusion. So contraindications, water intoxication, so it will absorb water, so you cannot give it for hyponatremic patients. Active coronary artery disease, because it causes significant vasospasms, and in patients with cerebral vasospasms, you have to have caution. And in late pregnancy, it has effect similar to oxytocin. It might induce labor. And it can cause severe gangrene because it's a very potent vasoconstrictor. So now a little bit about levosimendan and the newer agents, which are inodilators. Now I've talked about dobutamine already. Now I'm going to talk a little bit on levosimendan. And what levosimendan does it, so the beta-1 receptor in the myocyte will increase the calcium. Levosimendan will come and increase troponin affinity for calcium. When troponin binds with calcium, the actin-myosin interaction takes place more effectively. So the sensitivity is increased. As a result, the chronotrophy and the contractility will go up. Also, during diastole, it releases calcium easily also. As a result, there is going to be increased relaxation. So the diastolic function also improves with the use of levosimendan. So this is in the myocyte. Apart from that, it also acts on the vascular smooth muscle. What does it do? There's a separate receptor for levosimendan. When it goes there, the potassium, which is high concentration inside the cell, will go out. And it will cause a hyperpolarization of the cell membrane. As a result, the calcium will not work on the smooth muscle, and there's going to be vasodilatation. And in high doses, levosimendan actually acts as a phosphodiesterase inhibitor, which I'm going to talk to you about later. So if you compare levosimendan to dobutamine, which is our common inodilator, compared to dobutamine, the cardiac index goes up much higher. And compared to dobutamine, the heart rate goes higher as well, but not as much as the cardiac output. And also, if you look at the systemic vascular resistance, it drops very much, as well as the pulmonary vascular resistance. So these are the two drugs. This is the type of drug that you would use in patients who have right heart problems with pulmonary hypertension. Also, left ventricular problems where you want more of a inotropic effect and a vasodilatory effect where the afterload is not affecting your cardiac output. So levosimendan comes in this powder. It's very kind of unstable in room air. You have to keep it in the fridge. All the other drugs you can keep outside. And the powder is dissolved and it's given as, now these are not as short acting as our catecholamines. They are long acting, so about 1.5 to 3 hours. And in heart failure patients, it might take even longer time. And they're dependent on the liver and kidney for their metabolism, unlike your catecholamines, which are organ independent. So you have to give it as a bolus, then followed by infusion. The catecholamines, you don't do that because of their fast action. Here you have to give it. And the maximum effect will come in a little while. So you have to wait. You have to have some patience also. So that's about levosimendan. So let's move on to phosphodiesterase inhibitors. So where do they work? So you remember in the heart, the beta-1 receptor increase the calcium by increasing cyclic AMP through adenylate cyclase. Now this cyclic AMP breaks down very quickly to AMP. So the beta-1 receptor has to be stimulated continuously to keep a high level of cyclic AMP. When there's a phosphodiesterase inhibitor, the breakdown of cyclic AMP is stopped. As a result, the calcium will be high without the activity of beta-1 receptors. And from that point onwards, the increased chronotrophy, inotrophy, and lucitrophy will be there as for the catecholamines. And on the vessel walls, the beta, so again, it acts on cyclic AMP as for the heart cell. It stops it from breaking down. And when there's increased cyclic AMP, more calcium will be pushed into the sarcolemma. So calcium will not be there in the vessel. As a result, the smooth muscles will dilate. So it's again an inodilator. So compared to dobutamine, the dilatory properties of milrinone. So milrinone is the drug that I'm going to talk about here. It drops much more compared to dobutamine. And if you look at the map, with increasing doses, because of the vasodilatation, the mean arterial pressure might come down. You might have to add a vasopressor to overcome this. And if you look at the inotropic effect, the pure inotropic effect will increase the cardiac output by about this much, right? But because of the drop in the afterload, apart from the inotropic effect, the cardiac output goes up further. So you can see the total increase in the cardiac index in these patients. So again comes in this vial, 10 milligrams in 10 ml, and the indications are mainly for the heart, for cardiogenic shock, post-pump cardiac surgery, and cardiac failure with diastolic dysfunction and pulmonary hypertension. So they're mainly based on cardiac failures. And again, because of the long duration of action, you have to give a bolus followed by maintenance. But be careful when you give the bolus, the blood pressure tries to fall. And the half-life is prolonged. So you have to again wait for its action, sometimes unlike catecholamines. Yes. So with this, I thought the pharmacology is is enough. I have come to 8:40. So what I have not talked about are these drugs: ephedrine, phenylephrine, metronidazole, isopendine, dopexamine, and methylene blue. I'll just very shortly tell you. Phenylephrine and metronidazole are pure alpha-1 agonists, so they cause vasoconstriction. The good thing about them, they are used as, you can give them as small boluses as well as infusions, and they can be given through a peripheral vessel. And we use this mainly in anesthesia, where the anesthetic drugs will cause a drop in the blood pressure, but you do not want to start a potent drug as noradrenaline. So instead, you can start these. And ephedrine is another very attractive drug. Just keep this in mind. When you give, when your blood pressure drops due to, say, sedation, or when you're intubating a patient and you've given your drugs and the blood pressure all of a sudden crashes, you can use ephedrine. It's a alpha-1, alpha-2, beta-1, beta-2 agonist. So it acts like adrenaline. And the good thing about ephedrine is you can give it as boluses. So get it prepared to a syringe and you just give small boluses, and you might actually get away from starting a noradrenaline infusion, because you do not need it. Once the drug's effect goes off, the blood pressure will pick up automatically. So until such time, you can use ephedrine. And isopenylene is for bradycardias, beta-1 effect mainly. And methylene blue, yes, now it's coming up even in this sepsis. Methylene blue has its own mechanism of action. It reduces nitric oxide, which is a potent vasodilator. And for resistant shock, methylene blue has been recommended, but I'm not going to talk about it furthermore. So a few practical points. Potent vasopressors like noradrenaline, vasopressin, better to be administered through large venous vessels, such as the internal jugular vein, the subclavian vein, or the femoral vein. Short-term monitored use through vessels of caliber of more than 4 millimeters is accepted as long as you're monitoring it. So 4 millimeters vessels, you can find the external jugular on your neck or any vessel above the elbow. But for a person like me who's quite small, I don't think a 4 millimeter vessel can be found in me anywhere in the body. So be careful when you're using it on peripheral vessels. Other vasopressors can be given through peripheral veins, as I mentioned. So 5% dextrose is accepted as a diluent for these drugs. Now, the reason for this, I actually couldn't find out. But initially, when they used vasopressors or ionotropes and cardiogenic shock, they didn't want to give an added load of sodium by diluting this in 0.9% saline. So they used dextrose instead. I'm wondering whether that's that historical reason is being carried out still. So we have also actually using 5% dextrose to dilute this. And syringe pumps should be used to administer these infusions as much as possible. Avoid using burette sets because you know that the doses are very tiny, and even just a bit of being flushed through the central line or through a peripheral vessel for that matter can cause very disastrous effects. So it's always better to use a syringe pump to administer these drugs. And this is unfortunately an adverse effect occurred due to noradrenaline extravasation. So noradrenaline extravasation through a peripheral vessel doesn't happen just because the cannula has got dislodged. Noradrenaline has this huge ability to cause venous vasoconstriction because it acts on the vessel wall. And when that it is so profound that there will be no blood flow in that vein because it's small. And then that vein will die off because of the profound vasoconstriction, it will die off. And then the noradrenaline will start extravasating. And this is the ultimate effect result of that, blisters and gangrene, which it's kind of difficult to reverse. You can use an alpha-1 antagonist, but still there are no reports of saying that this was completely reversed. You might have to cut off the limbs also. And some other practical points. When you're using these, quite strong drugs, you have to monitor parameters very regularly. Blood pressure every 5 minutes, heart rate continuous, ECG continuous. You can't just put them on an noradrenaline infusion and come back in 1 hour and monitor them. That's not accepted. You have to put them on a multi-monitor. And we would prefer to use an arterial beat-to-beat pressure monitoring, and which will, especially if the patient is on one supporting drug on high doses or at all times when they are on 2 or more vasopressors or ionotropes. And ideally, if in an ideal world, these patients should be managed in HDU, if not in an ICU. So now I have told you about all the drugs that can be used. So what drug is most suitable for me? That's the question that we have to answer at the end of the day. So we'll just go this case scenario and see how that. This is a patient that I've managed when I was in UK. So it was a 46. So some of the things that we have done here might not be, applicable to Sri Lanka. But and as an ideal case, I thought I would share this with you. This 46-year-old man presented to the emergency department with right loin pain, with pyrexia and vomiting for 24 hours. He's a known diabetic. He was tachypneic. There were some right basal crackles and saturation was low on air. He was tachycardic. And look at the blood pressures, 82/44. The diastolic is very low. He's confused and his urine output is coming down, and the temperature is also high. And if you look at the blood gas, there was a metabolic acidosis, complete metabolic acidosis, where with a respiratory compensation and a high lactate. And there they do CTs very it's not very difficult to get a CT done. And we got a CT done, and to see that the right kidney had some hypodense areas as well as some emphysematous areas, and it was edematous. So infection of the right kidney was diagnosed at this time. And before the blood gas was done, they have actually given a Hartmann's fluid, not knowing the lactate was high. And then after 500 ml of blood, and they looked at the lactates again, and it was 7 actually. It has got worse than the previous, and the base excess has also got worse. And then they referred the patient to us, and we told them to give more further fluids, 0.9% saline, and we gave up to about 30 ml per kg. And this is according to the surviving sepsis guideline. And the systolic blood pressure actually went down further, and the tachycardia got worse, and he was still having respiratory distress. We made a diagnosis of septic shock, and the patient's oxygen requirements were also now going up. And the patient was brought to the ICU. He was maintaining his airway. He was on high flow oxygen, high levels of oxygen. There was some reduced air entry on breathing assessment, and the saturation was 90. And the respiratory rate was increased, so we started him on CPAP. The systolic blood pressure was low, and the MAP was still low. Heart rate was still high. Capillary refilling time was prolonged. We took all the bloods, the cultures, and all the investigations. He was on ceftriaxone. We escalated to meropenem. And we started noradrenaline 0.2 mics per kg per minute at this point. And we took the patient in the same night for a percutaneous drain to the collection of that kidney, and a nephrostomy was done for decompression, and the samples were taken from that as well. Now, by this time, the patient was further hypoxic, and the respiratory rate has gone further up. The pH has got worse, and the base excess was getting worse. And we did the X-ray, and it was kind of going into diffuse homogeneous opacification, kind of an ARDS following sepsis. So we thought we would electively intubate this patient, and we started ARDS net protocol ventilation. Now, the noradrenaline by this time has gone up to 0.5. The MAP was 6, still 55. Our target, according to the surviving sepsis, is 65. And the urine output was low, and now he was in established AKI, stage 2. And by 24 hours of admission, so there we have this habit of inserting arterial lines to all patients. And in patients like this, we do something called cardiac output monitoring. That is, this monitor is connected to this patient. This is the basic monitor. And because we have arterial blood pressure, we have beat-to-beat monitoring of the blood pressure. And you can see the diastolic pressure is very low in this patient. He's tachycardic. And the CVP was also transduced, which was 5, which is not, it's not that much. We would prefer to have it a little bit higher. And the saturation was 90, again, marginal. And here is the cardiac output monitor. If you look at this, it's not that clear, the picture, but this is the cardiac index, which should be about 2.5. So it's very low. So the cardiac output is not that great. And stroke volume variation. So, you know, you'd check the pulse. With breathing, there is change in the volume of your pulse, which we usually appreciate in our patients as well. So we can do this in a machine as well. And this is depicted as stroke volume variation. If the variation between the highest stroke volume and the lowest stroke volume is more than 18%, we consider that patient to be volume responsive, fluid responsive. So as you can see, it's about 21%. So we can afford to give some fluid to this patient, more fluid in this patient also. And this is another parameter we look into. This is the central venous oxygen saturation. So arterial saturation will be about 100%. When it comes back to the right heart, it will be about 70 to 65%. So the rest of the oxygen has been extracted by cells. But now it's 49, means that the oxygen, the body is getting deprived of oxygen, and it is extracting more oxygen from the capillaries. As a result, the central venous oxygen saturation is now going down, which indicates that the oxygen supply is not enough. So we have to do something to bring this back to 65 to 70. So what did we do? So the first thing, the obvious thing was the stroke volume variation, which was high. We gave fluid boluses until the stroke volume variation came up to about 12%. So this 21% to 12%. And at the same time, because the diastolic pressure was low, we started a vasopressin infusion. He was on NORAD 0.5 and vasopressin infusion on a maximum dose. And we started hydrocortisone, shock doses. And with the fluid and the vasopressin, the map actually picked up. And you can see the diastolic pressure has gone up also. So vasopressin, most probably the vasopressin has has reversed the vasoplegia to a certain extent. And the SCVO2, that's central venous saturation, also picked up to 70. So that means by increasing your vascular resistance and increasing your cardiac output, you have increased your oxygen delivery. And the lactate came down to 4 millimoles. Unfortunately, the following day, the BP dropped again. And the CVP, which was 9 after the fluid, initially it was 5. With the fluid boluses, it came up to 9. It went up to 15. And this, the central venous oxygen saturation dropped to 63. Again, it was indicating that the oxygen delivery was not enough. And to see the lactate was also going up. And we did a bedside echo on this patient. And if you can appreciate, the heart is not moving at all. Let's play it again. Yeah. So we thought this was due to a secondary sepsis-induced cardiac insult, because it was a global hypokinesia. There was no indication of acute ischemic event at this point. So we started a dobutamine, 10 mics per kg, because we had evidence of cardiac insufficiency. The blood pressure did rise to MAP of 65, but there was a persistent metabolic acidosis. We were giving sodium bicarbonate intermittently, but it didn't kind of resolve the problem. And the lactate was still high. And to find that the creatinine and the urea were also now going up because he was in established AKI. So we thought we would start him on continuous veno-venous hemofiltration, which was started. So usually when this happens, if your source is controlled and you're doing the correct thing, the patient becomes better over the 24 hours or 48 hours. But this didn't happen to our patient. So we were thinking why? And the sugar control was fine. And we were covering with antibiotics. But we repeated an ultrasound just to see that actually the kidney, the state of the kidney was getting worse. The collections were extending. So despite the patient being on 2 vasopressors and an inotrope, we took him into theater. The minimal invasive interventions were not working. So we actually had to do a nephrectomy to remove the whole kidney. And with this source control, the patient kind of went into a severe septic storm, but then afterward he's improved. His metabolic acidosis resolved, the lactate became less than 2, and the cultures actually revealed an extended spectrum beta-lactamase, which was sensitive to meropenem, but did not respond because the source was still there. So we have removed that, and so it's a happy story actually. This patient recovered and went back. So from this case, I just wanted to show you how rationally we try to use our vasopressors and inotropes in these patients. Because what we see when patients come to the ICU in our setup is like these patients are on about 4 vasopressors, inotropes, 4 on them, and still the blood pressure is very low. So why they were added was kind of confusing to us as well as the team who bring the patients over. So we will try to be more rational when using these drugs. And to explain it a little bit more, I hope it's okay. I have just one more case. After this, it's done. So we are now currently treating a 68-year-old patient who's having diabetes, hypertension, and ischemic heart disease, who was treated for a septic wound in a surgical ward. He developed a VT with pulse while in the ward, which was managed electrically and pharmacological cardioversion. And later on, it converted into a VT cardiac arrest, needing 40 minutes resuscitation. He was intubated in the ward and sent to the ICU on NORAD 0.5 mics. And when he came and when we put the monitors on, his blood pressure was 110/75. Look at the diastolic, it was okay. So this patient was most probably in cardiogenic shock rather than a vasodilatory shock. But he was cold in the peripheries and the capillary refilling time was extended. He had a high oxygen requirement, and there were basal crepitations, and there was no urine output. So this indicates cardiogenic shock because there is less perfusion. The kidneys are not getting perfused and the peripheries are cold. So seems to be cardiogenic shock. And this is the hand where his noradrenaline was attached to. And you can see some extravasation has already started. And this was initial blood gas. There was severe acidosis, which was both actually metabolic. You can see the base excess -11 and respiratory, and the lactate was 9.4, and the potassium was starting to rise also. So This was the X-ray, kind of a cardiomegaly, but this was a AP1. And the pulmonary edema is showing here. And you can see the heart, the bedside echo, LV function is reduced. And the IVC is also here, which is not, getting compressed. And the bases of the lungs had D lines, suggesting pulmonary edema. ECG did not reveal acute ischemic event leading to the cardiac arrest, as we had a discussion with the cardiologist, and the ejection fraction was low with global hypokinesia. The reason being, we thought of due to the arrhythmia. And by this time, the ASTs, ALTs have gone above actually 2000, if we talk about 2000, and so he has gone into liver failure, and the creatinine has also gone up. So we have come to a phenotype of cardiogenic shock, where it is a cardiometabolic cardiogenic shock, which has the worst prognosis of all the phenotypes of cardiogenic shock. And so we thought, because he's having very high vasoconstriction, we would vasodilate him. So we started him on a bit of dobutamine, and we started to wean the noradrenaline quite quickly. And because he was wet, this was a wet cold cardiogenic shock, we started him on IV furosemide as well. Now, after 3 hours of this therapy, you can see the pH has improved, but mainly because the carbon dioxide has been washed off. But the lactate has gone down. So that was a quite a revealing factor. The potassium was still high. And if you look at the anion gap, it has actually worsened. To make things worse, he went into decay also, which I'm not going to talk about here. But we'll talk about how we manage this cardiogenic shock. We changed the line into a central line. And this was the burette he had the noradrenaline with, but we changed over to this syringe pump. And it's 5 millimoles, as you can see. And we have actually stopped the noradrenaline by this time. And this is the blood gas after about 48 hours. As you can see, the pH has almost normalized, but still the PCO2 is a bit high because of the pulmonary edema. It's kind of difficult to ventilate this patient, but the lactate has come back to normal. So that indicates that the patient is getting it's coming out from this cardiogenic shock. And the bicarbonate has resolved. We have given some bicarbonate also for this patient. So according to the AHA journal, Journal of AHA, which was published last year, proposed vasoactive treatment strategy for cardiogenic shock. You assess the patient. If the patient is hypotensive, you go for early mechanical cardiac supports, which unfortunately, even in a hospital like Colombo North Teaching Hospital, is not available. So then the next best thing is the pharmacological approach is to commence norepinephrine. And then you assess the patient. If the patient has a low cardiac output state, which is demonstrated by low mentation, low urine output, peripheries, cold peripheries, or high lactate, you would start an ionodilator, which is in our setting most probably going to be dobutamine or milrinone. And if with noradrenaline your blood pressure does not pick up, they actually say to consider vasopressin. It's not a recommendation, they say to consider it, unless you already can start on a mechanical cardiac support. And if it's not responding to vasopressin, they rename it as refractory hypotension. Again, an indication for mechanical cardiac supports, but if you don't have that, methylene blue can be used in this case. And if in the initial assessment, if the patient is normotensive, but still has low cardiac output as being denoted by the things that I've said earlier, you still anyway, even though blood pressure is fine, if there's peripheral perfusion is poor, you would start a dobutamine or a milrinone. And if with that, if the pressure start dropping, then you can start a norepinephrine. So I have shown you the indications of noradrenaline and vasopressin in the setting of cardiogenic shock also. So I don't think you have to be very much afraid to use these drugs in cardiogenic shock. So an update, the patient is still in the ICU, still ventilated, and he's still on dobutamine 5. CRRT was not possible due to lack of consumables, but he underwent 2 successful hemodialysis despite having ejection fraction of 25%. Liver functions are coming down, and sorry, the X-ray is actually kind of getting better. And most importantly, he's obeying commands and his pupils are reactive. So that's a good sign. He might recover. Let's see what happens to him. So with that, I have come to the end of my talk. And yes, I am open for questions if anyone has.
Thank you, Dr. Mudalike. Actually, we have several questions. We'll go ahead with them one by one. What is the difference? What is the difference? What is the difference? Better adrenaline action in anaphylaxis and cardiac arrest dose-dependent action.
Why it is better over noradrenaline, is it?
Uh, Not quite sure what is the difference.
Ah, yeah.
Uh,
So why do we use adrenaline instead of noradrenaline, right?
uh,
Yeah. So even for adrenaline, there are no, robust randomized control studies where they have proven adrenaline to be better over noradrenaline. But adrenaline, as I said, in anaphylaxis and cardiac arrest, in both settings, we use it in aim of causing a massive, profound vasoconstriction. So in order to do that, the only drug that we can give as a bolus, as up to now, is adrenaline. So I've already mentioned you the two doses. So you can give it as a bolus then and there. And then it will cause profound vasoconstriction, and all the blood in the venous system will come back to the right heart. And then when you're giving the compressions, that venous return will with the positive and negative intrathoracic pressure that you're creating with your cardiac compressions will go back into the arterial system and will, perfuse your heart and your brain. So that's the aim of giving it. They have tried noradrenaline, they have tried vasopressin. There are so many studies. If you just go into the literature, they have studied all these drugs, but it has been the norm kind of. So there's no specific randomized control study saying that adrenaline is better over noradrenaline or noradrenaline is better over adrenaline in these two circumstances. But it's the norm and we are still using it. There's nothing saying this is better than the other. Sorry.
I think we have answered this second question.
Yeah.
People are still using renal dose dopamine. Does it really exist?
No, it doesn't actually.
It does.
Yeah, if you use renal dose, dopamine in a group of people, and you do not use it in another group of people, say you do a randomized control trial, which has been done, the percentage of AKI that occurs in either group has not been statistically significant to promote a renal dose of dopamine over any other drug. So, and also in that paper, that was a landmark paper that I just showed you. They showed like when you're using dopamine, I've already explained this, the rate of arrhythmias is much higher. And the death rate in cardiogenic shock is also much higher. So if there is no like kind of an actual benefit of using it, apart from the cost, of course, as I said, the cost is much less. So you can use it. You don't have to like avoid it completely, but don't use it in terms of, improving your kidney function. You can use it as a vasopressor.
What is the pathophysiology of picking up the BP after weaning off the effect of epidrine? Actually, epidrine when administered during hypertension.
I'm sorry, I didn't get that question.
So, what is the pathophysiology of picking up the BP after weaning off the effect of epinephrine when administered during hypertension?
Ranga, do you understand the question? Like,
No,
can you like
no,
tell me?
actually, I'm not quite sure actually. What is the pathophysiology of picking up the BP after weaning off the effect of epinephrine?
I mean, after adrenaline is weaned off, why the blood pressure picks up, is it? Okay, let's say if that
Yeah,
is the question, that means the initial pathology has resolved, right? If the
yeah.
patient has gone into a shock and you have started adrenaline, and at some point, if you are coming down on the adrenaline, that means the initial reason for the shock has resolved. Apart from that, there is no other pharmacological basis of adrenaline's action being prolonged or anything, because as I said, it's very short. If you stop adrenaline, its effect will go off. So that means the patient is by himself maintaining his cardiac output and his systemic vascular resistance. I'm not sure whether that's the answer that the person who asked is expecting.
Yes.
Yeah.
And the next one is I have seen milrinone used in pulmonary hypertension patients. You said that the levosimendan can be used in pulmonary vasodilator as well.
Yeah.
What is the first choice in the context of pulmonary hypertension with right heart failure?
I don't know about that. So again, levosimendan is very, very expensive compared to milrinone. So if you're talking about cost, I think you would go for milrinone. I don't think levosimendan is even licensed in the USA. And I'm not sure whether we are using in Sri Lanka levosimendan. I have not been to the cardiology unit recently, but milrinone, of course, will be using. But I didn't actually go through milrinone and phosphodiesterase to that extent to see whether one is better over the other. But cost-wise, of course, I would go for milrinone. Otherwise, the pharmacological effects are similar. So I'm not quite sure the adverse effects or any other effect is different between the two. Sorry.
Is there a maximum dose of noradrenaline giving via peripheral vein?
Is there a
Maximum dose for norad to give via peripheral vein.
So no, the recommendation is to use NORAD on a peripheral big vein for a minimum period of time and get a central access as soon as possible. So they have not actually said the maximum dose, but I would say if it was up to me, if it goes beyond kind of 0.2, 0.3, I would not use it on a peripheral vessel. At least get a green cannula into the external jugular, which is almost kind of quite big. But when you go up to doses of 1 mic, no, don't use it. It's too risky.
What are the ionotropes and vasopressors that we can use in patients with decompensated CLCD with low blood pressure after giving fluids?
Mainly, it would be vasopressin. In chronic liver disease, it would be vasopressors. Because in chronic liver disease, the pathology is vasodilatation because of the increased cytokines that is not being detoxified by the liver. And these will go all over the body and it will cause vasodilatation. So the pathophysiology is that. So the antidote would be a vasopressor. And in terms, noradrenaline and vasopressin both can be used. But when it comes to this portal hypertension and all, vasopressin comes, a little above than noradrenaline. So anyway, if you're starting, if I'll say like this, if you're starting off in a CLCD patient who has gone into acute liver failure and is now starting to drop the blood pressure, you can start with noradrenaline. And when the dose goes up to about, let's say 0.3, that at this point you would start vasopressin infusion as well. And about ionotropes, the heart is already hyperdynamic in these patients. So you would hardly need ionotropes in these patients. And also you have to keep in mind this dobutamine, they cause vasodilatation. So it's counterproductive. So try not to use it. And adrenaline, well, you can use it, but when you have vasopressin and noradrenaline, you should always try them first. And adrenaline and everything else comes later on.
Can vasopressin further reduce urine output in patients with sepsis and AKI if started after noradrenaline?
This has not been shown, in literature to vasopressin to increase the incidence of AKI. Actually, it's the opposite that happens. But let's say in a patient who has started off with the AKI stage 1 and gone into stage 2, and now you're going up on your, so he's going from pre-renal, he's going into renal failure. Wow, once the renal failure is established, starting any vasopressor or inotrope or even a diuretic will not work. So I don't think you should attribute it to vasopressin, because vasopressin, if started at the appropriate pre-renal time, will actually bring up the renal perfusion because of the rise in the MAP and would prevent the patient going into renal failure. Once in established renal failure, if you start vasopressin, it will not worsen the outcome because the renal failure has to recover by itself. Either maybe you might have to go for renal replacement therapy, but it will recover by itself because it's ATNs that occur and they will recover. But thinking that there is AKI, you should not avoid vasopressin.
What are the implications of using strengths as opposed to per kg doses of noradrenaline infusion in ICUs?
Yeah, it's strengths and per kg dose are the same basically. So what happens is if your patient is not that much of a shock, let's say the blood pressure is 90/60, and you can go off with a dose of 0.2 mics per kg per minute. What you do is you just add 2 vials of noradrenaline to that 50 cc, so that concentration is lower. So only a low volume of that infusion will go within that minute. But now the blood pressure is not picking up and you have to go up on your dose. Now 0.2 is not working, you are going 0.3, 0.5, 0.6. Now what happens? You have started with a lower concentration in that syringe, and that syringe will, be used quite quickly, and you have to change over the syringes very frequently. And even in that moment, when you change that syringe, the blood pressure will crash because of the short half-life. So that's very dangerous. It's better in that case to go for a higher strength. Like instead of using 2 vials of noradrenaline in 50 cc, you might go up to 4. So the concentration of noradrenaline is high. As a result, the infusion rate, mils per minute, will be low. So your syringe will not get over. But the dose will be the same. If it's 0.2, you will be, maybe this is just an example, if it's 0.2 mics per kg per minute, if it's single strength, you might be infusing about 8 ml. If it's double strength, you will be infusing about 4 ml per minute. So the strength is the same. The dosage is the same. It's only the concentration in that syringe that changes.
If vasopressin is not available in a hospital setting, what should we use as a second inotrope together with noradrenaline in septic shock?
Then whatever you have, isn't it? So I think apart from dobutamine, if you don't have evidence of low cardiac output, I think you should go for adrenaline or dopamine. So that's the plight of the country.
Yeah. And I think we have discussed this place of corticosteroids in shock.
Yeah. So this is basically, this is in septic shock, not in other types of shock. So they have said, like in septic shock, there are two studies actually that have shown that if you use what they say is, with the hypotension, the adrenal medulla will adrenal cortex will reduce with the reduction in the blood flow, the cortisol levels will go down and they go into kind of a relative Addisonian kind of a state. And also the sympathetic effect needs adequate cortisol levels. So they have used this physiological kind of doses, that is 200 milligrams per day of hydrocortisone. And actually, the two studies were contradictory. They have not actually shown a major kind of difference in mortality, but definitely there was no, adverse effect or increased mortality due to the use of corticosteroids. So it is recommended, it is given as a recommendation in the surviving sepsis guideline to use this IV hydrocortisone 200 milligrams as an infusion, or 50 milligrams 6-hourly bolus amounting to 200 per day.
Right. In the absence of any more questions, I would like to thank Dr. Anushka Ampudige for
Hey, Ranka, can you just give me a second? I just want to give a summary because it like kind of highlights what I had to say. Is it okay? Just one slide, right? Yeah. So in summary, vasopressors, the vasopressors and ionotropes are a unique group of drugs that cause cardiovascular stability in shocked patients. Their different pharmacological properties result in specific changes in the hemodynamics. So knowledge about this change, the pharmacological action, and the skills to utilize these drugs accurately ensures that a positive outcome in patients. But you have to remember, now we are going into that era that one size does not fit all. So you have to know your patient, you have to know your drugs, and you have to individualize what you're using onto that individualized patient, which is called precision medicine, which is the way forward from this point onwards. Okay, then that's it. Thank you. Yeah.
Thank you. Thank you very much, Dr. Anushka. Maliki for her excellent and very comprehensive lecture. And I'm glad to say so far this year we have had nearly 180 participants for this lecture. That
That's
is
good.
the highest participation for this lecture series actually.
Good. Good to hear.
And thank you very much for your time. And and actually, when I asked from you to present this lecture, you didn't even hesitate a minute to answer. You said yes, and thank you very much for that. And also, I would like to thank the SSC president and the council for letting me organizing this event. And at the same time, I would like to thanks the audience as well as Mr. Dishan and the guest farmer team for sponsoring and coordinating the event. And thank you all very much. Good night.
Thank you.
Thank you.